How's it going, guys? It is 3:28 a.m., the 24th of November, Thursday here in Japan. We have a pass level question for surgery for 2CK. Difficult question for step 1 for renal. Before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at mehlman_medical, mehlman_medical. Links down below. Find me on Telegram. Links to the Telegram group and channel down below, and I start the clip. So 77-year-old woman, she's brought to the ED. Vitals are within normal limits. Protein on, so urinalysis. Protein, none. Blood, 3+. White blood cells, 0 to 2 pi per field. Red blood cells, 3 to 4 pi per field. Question wants to know the most likely explanation for her presentation. So let's just whip through the answer choices here. Choice A, acute glomerulonephritis. Wrong fucking answer. Very generic, non-specific answer choice that I have seen on nbme content as a correct answer for PSGN, post-streptococcal glomerulonephritis, okay? PSGN is also known as just proliferative glomerulonephritis, not membranoproliferative, not diffuse proliferative. If you wiki PSGN, you'll see AKA known as proliferative glomerulonephritis, okay? So PSGN is going to be red urine, hematuria, 1 to 3 weeks, okay, weeks after a sore throat or a skin infection, cellulitis, impetigo, erysipelas, okay, caused by strep pyogenes, group A strep, clearly. And it's a type 3 hypersensitivity. A lot we can talk about. Point is, wrong fucking answer. Choice B, glomerulosclerosis, wrong answer. Obviously, this also sounds quite non-specific, but would refer to diabetes in theory because diabetic glomerulosclerosis, okay? Once again, tons we can talk about. You should know the first change in the kidney with diabetes is hyperfiltration. I made one of my previous audio Qbank questions on it within the past few days, okay? And you're going to see hyperfiltration followed by thickening of the glomerular basement membrane, okay, non-enzymatic glycosylation, which will cause loss of charge and size barrier, and then ensuing nephrotic syndrome. Of course, you can get chymal Steele-Wilson nodules, which are hyaline, and they will appear as large eosinophilic, which means pink. So eosinophilic circles when you do biopsy of the glomerulus. Wrong fucking answer. Choice C, IgA nephropathy, wrong answer. This is going to be red urine hematuria, 1 to 3 days after a URTI, upper respiratory tract viral infection. Now, I emphasize this because, you know, students get confused over this, but it's pass level, as I said. So you're going to have red urine 1 to 3 weeks after a sore throat. That's PSGN. Red urine 1 to 3 days after a sore throat. That's IgA nephropathy viral infection, okay? IgA nephropathy, you'll get IgA deposition in the mesangium. This can occur on its own from viral infection or GI infection sometimes, or it can occur as in constellation with henoch-Schönlein and purpura, okay? More pediatrics for 2CK, high yield, non-existent on step 1, but that's going to be red urine, IgA nephropathy, a tetrad. IgA nephropathy, number 1, red urine. Number 2, obviously palpable purpura, okay, on the buttocks, thighs. 3, arthralgias. 4, abdominal pain. In this case, wrong fucking answer. Choice D, interstitial nephropathy, wrong answer. So this 4 out of 5 times is going to be a beta-lactam cephalosporin or NSAID followed by eosinophils in the urine. They can just write white blood cells in the urine. Okay, it's an allergic reaction of the kidney. They can say a rash, a maculopapular rash, in about 50% of vignettes. You don't have to have the rash, okay? So if they give you, for instance, an aminoglycoside, and then you have a kidney issue, that's acute tubular necrosis, not interstitial nephropathy. If they gave you dapsone or sulfonamides, then a renal issue, that's going to be membranous glomerulonephritis, a nephrotic syndrome, not interstitial nephropathy. So interstitial nephropathy or interstitial nephritis, aka tubulointerstitial nephritis, that's going to be an NSAID, beta-lactam, or cephalosporin followed by white blood cells in the urine 4 out of 5 times, okay? And 1 out of 5 times, they can just say mild proteinuria, hematuria in a patient who's been on NSAIDs, okay? They can also just give you a patient who has peripheral edema who's on NSAIDs, and you say, well, that sounds like pre-renal, okay? There's no white blood cells in the urine, it's just edema in someone on naproxen for 6 weeks, and then they just have as the answer interstitial nephropathy, okay? But 4 out of 5 times, you're going to see eosinophils in the urine with a maculopapular rash, plus or minus. Very high yield for USMLE. In this case, wrong fucking answer. Choice C, nephrotoxicity, is the correct answer. Okay, I intentionally made this a vague / nebulous answer choice. This is rhabdomyolysis causing acute tubular necrosis because myoglobin is nephrotoxic. Okay, what we have here is what's referred to as a false positive blood on urine dipstick. So this is what USMLE is going to do. They're going to intentionally give you a very vague vignette. It's, to my observation, they like giving you someone found on the floor in their house. I'm not joking. Like, I've seen this same fucking vignette across different forms where they'll just say, old lady found on the floor in her house by her staircase. I saw another one with like a young woman found on the floor in her house by a staircase. They can give you an alcoholic. That makes it easier because alcohol is a risk factor for rhabdo, very high yield. And you're going to get a false positive blood on urine dipstick. Now, 3 to 4 RBCs per powered field is negative. I've seen this on surgery forms. It doesn't have to be 0, okay? There's no specific cutoff. But if they want positive, they might give you 20. They might give you 50. Okay, so just subjectively under 10, but 3 to 4 I've seen as negative. Okay, the reason it's a false positive blood is because the dipstick can't differentiate between the hemoglobin actually on RBCs and free myoglobin. Okay, but myoglobin is nephrotoxic. It causes acute tubular necrosis. They don't have to say muddy brown, dirty brown granular cast or brown pigmented cast. They don't have to do that. They can just give you the same fucking vignette here, and then rather than nephrotoxicity, they can just have acute tubular necrosis. No mention of casts, of muddy brown granular casts, nothing like that, okay? Or they can just have rhabdo. Make it easier, just what's the diagnosis? But what they're going to do on 2CK in particular is make the question very fucking long with tons of lab values, and you're just going to see, boom, blood is present, maybe 2+, and then there's negative RBCs, and you're like, that's just a false positive blood, that's rhabdo. Answer is ATN, or answer is just straight up rhabdo, okay, nephrotoxicity. Very important factoid for USMLE, knowing this urine finding for rhabdomyolysis. You know the deal. I'm going to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.